expiratory film. No, I didn't. I wanted something else. Left outer border straight. No, I'm asking you the difference between the two X-rays. Exposure. No. Okay. Now, if you look, both are from the same patient, by the way. If you look at it, this X-ray looks a nice X-ray. The heart size, normal heart size, CTR looks normal. The X-rays are, the clavicles are quite horizontal. You see the apical portion of the lung, and the scapula is not overlapping the chest. Those are the signs of a postero-anterior X-ray. If you see the apical regions well, you see the clavicles are horizontal, and you do not see the scapula overlapping the chest, it indicates that the chest X-ray has been taken postero-anterior, and that's what we want. If you note carefully, now the CTR is not much bigger in this. Now here, the apex is not clear. The clavicles are oblique, and the clavicles themselves are, and the ribs are partly obscuring the apical regions of chest. And you can see that the scapula is overlapping the chest. Can you see the scapular border here and here? Here. Therefore, the one on my left is a postero-anterior chest X-ray, which is what we want, and the other one is an anteroposterior chest X-ray. There are two. Are you able to see my arrow? Are you able to see?
Arrow is not seen.
Oh, you won't be seeing my arrow. Okay. Then it will be difficult. That's one of the problems. Okay. So this is one of his postero-anterior, is better for CTR evaluation, for lung field evaluation, and that's what we prefer. But sometimes in a supine child, in an uncooperative child, or in an ICU when a patient is on ventilator, you have no choice but to take an antero-posterior chest X-ray. Right. Now here there are two X-rays. It's quite obvious which X-ray is better. One X-ray is heart size, heart is in the center. You see the normal configuration.
Sir, actually pointer is not visual, sir.
I know. How do you?
You can use the arrow.
My arrow, they are saying it is not visible.
Nothing, sir.
I am using now because I am sharing the Microsoft PowerPoint. I'm not sharing.
I'm not able to see this, sir.
Okay. Can I just come out and share my desktop? Then it might be visible.
Yes, sir. You may try.
I'll just stop sharing for a minute. Can you give me sharing? I'll try sharing again. Can you see my screen?
Yes, sir. I can see the screen, sir.
Can you see my arrow?
No, sir.
No.
Move your arrow, sir. I'll try to see. No, sir. Nothing. I can't see anything.
Come out again and try that. Once again, I'll try it again, huh?
Now I can see that. Now I can see this, sir. Go to the slideshow.
Okay, now I'll go to slideshow.
Now again, just try to move the arrow.
No, this one is not.
No, sir.
One second.
Sir, do the right click.
Huh?
Do the right click of the mouse or touchpad.
No. Oh, hang on one moment. I'll just. I'll try sharing again. Are you seeing the screen?
No, sir.
1 second. Now can you see my arrow?
Yes, sir.
Yes, sir.
Okay. Now?
No, sir.
Oh, when I go to slideshow, it's not visible. I don't know why.
Okay, sir. We may continue without like that.
Okay. Right. Sorry. Okay. Now, the X-ray on my right is a good centered X-ray. If you notice, there are two fingers have been superimposed on the chest X-ray, and they are equidistant from the midline. That indicates the X-ray is well centered, and therefore the cardiac silhouette is likely to be normally profiled. That means you see 1/3 of the right heart on the right side of the sternum and 2/3 on the left side. Now, in this view, the configuration of the heart is likely to be reliable. On the other hand, the X-ray on my left, you see that if you put two fingers on the medial end of the clavicle, the distance from the midline is quite uneven. That means the patient is twisted to one side and it is an oblique view. And therefore, it will not. Here appears that the right side is markedly enlarged and there is hardly any heart on the left side of the spine. Therefore, this doesn't give you a true impression of the cardiac silhouette or the cardiac size. Therefore, you must make sure that the chest X-ray. Therefore, first is posterior or anteroposterior. Secondly, whether it's an oblique view or it's a well-centered view. And thirdly, whether it's an inspiratory film or an expiratory film. These are the three characteristics that you have to check before you go on to measure the CTR. Now, inspiration and expiration in adults can be controlled. You ask them to take a deep breath and hold it. In children, it's a matter of chance. Sometimes you'll get a expiratory film, sometimes you'll get an inspiratory film. Right. Now, this is something very, very basic, which everyone should know, and I know most of you will already know it, but I want to repeat it. Sometimes in the exam, you fumble when I ask you how did you measure cardiothoracic ratio. Now, cardiothoracic ratio is the maximum dimension of the heart, but it's not measured in a single line. You take the maximum distance of the right heart from the midline and then in a separate point measure the maximum distance of the apex from the midline. So add these together, that is the cardiac dimension, and you take the maximum dimension of the internal chest, the inner border of the rib at the maximum point, that gives you the thorax ratio. Now, generally books say that 60% is a upper limit of normal cardiothoracic ratio. That's all right in a vertical erect patient in a deep inspiration, but in a child, often supine, often some partially expiratory film, even a normal heart may look bigger, and therefore cardiothoracic ratio above 65% would be clearly abnormal. 60 to 65 could be normal or abnormal. Okay. So don't jump into 60% and the heart is abnormal. Right. Now, the next most important step in the reporting of an X-ray, and especially because congenital heart disease is an important part of our practice and of our exam, is the situs. The most straightforward clue to situs is look at the stomach bubble, cardiac shadow, and most of the time you don't see the liver fully because it's not a chest and abdominal X-ray. Therefore, if you see the heart mostly pointed to the left and the stomach bubble is also on the left side, in the vast majority of cases, that is situs solitus. And the X-ray on my right shows a typical X-ray in a situs inversus, where you see a stomach bubble on the right side and you see a major cardiac mass pointed to the right, and you see the apex. Now, apex is defined by the downward and outermost point of the heart, and that is also pointing towards the right. Therefore, this X-ray fits situs inversus with dextrocardia. Now, dextrocardia and levocardia are defined by two terms. One is more than 50% of the mass right side or left side, and where the apex is pointed. both criteria are taken into account when you describe dextrocardia. Sometimes you may have a major cardiac mass on the right side, but apex still pointing to the left side. Quite possible. Just like anatomical, mechanical shift of the heart from left to right, the cardiac mass may appear to be on the right of midline, but apex will still point to the left. In that case, you have to describe what you see. Now, sometimes the situs is not so straightforward, and it gets confusing. It's important for pediatric cardiologists and to some extent adult cardiologists also, and therefore we have a variety of combinations. For example, the first one shows situs solitus. You can see many clues are used to determine situs in a complex heart disease. One is the stomach bubble and heart shadow. I already told you. Next most important thing is the liver, because children we often get an X-ray going all the way from chest to abdomen, and you will be able to see the liver also. For example, here you can say that the liver is on the right side. In the first X-ray on the left, you can see that the liver is on the right side and the stomach bubble is on the left side, heart is on the left side. Therefore, everything looks normal, situs solitus. If you go to the X-ray on the top right, you see that most of the cardiac mass is on the right side, the stomach bubble is on the right side, and the liver mass appears to be on the left side. Therefore, we get what is called a situs inversus dextrocardia. Now, bottom two X-rays are problem. The bottom left, the heart appears to be pointing to the left, but the stomach bubble is not clear. I don't see a stomach bubble clearly either on the right side or on the left side, and the liver seems to be extending all the way from the right to the left. Can you see that? Unfortunately, I'm not able to point it out. The bottom left one, my left, okay, as you're seeing me, my left. Therefore, now the cardiac situs suggests situs solitus, but the abdominal situs is not clear. Therefore, in that case, you think of a situs ambiguous. Situs ambiguous. Now, similarly, the fourth X-ray, the bottom right, my right bottom, the heart seems to be on the left side, clearly on the left side, but the stomach bubble is on the right side. So there is a discordance between the cardiac situs and the stomach situs. Now, whenever you have a discordance between the heart situs and the visceral situs, you have problems. It indicates almost always the underlying heart is abnormal, and usually it's a very complex heart disease. Now, there are some more clues to the for example, whenever there is situs abnormality, even the right lung and left lung gets inverted. Therefore, if you happen to see the fissure of the lung, the most commonly seen fissure in chest X-ray is the minor horizontal fissure in the right lung. If you happen to see that fissure, then it's very useful. You know where the right lung is. So right lung should be normally on the right side, and the left lung should be on the other lung should be on the left side. So sometimes you get a right lung on the left side and left lung, and also aortic arch. You can identify left aortic arch and right aortic arch. I'll come to that a little later, and therefore that is also helpful in determining the solitus. Okay. Now, to assess the bronchial situs is also important, because bronchi, more than the abdomen, liver, stomach, and all the other structures, the bronchus is supposed to be the most reliable guide to situs. Now, this again, not very important for adult cardiologists, but pediatric cardiologists need to go back and read about it in a textbook of radiology, because you will understand it better. Now, normally the right lung has a early upper lobe branch coming off. So therefore, the length of the right main bronchus is short, and the length of the left main bronchus is longer. The right bronchus is shorter, more in line with the trachea, and it gives off an early branch to the right upper lobe. Whereas the left main bronchus is long and continues for some time before it gives off a branch. I don't know whether you see it here in the right upper X-ray. You see the typical right bronchus, and you also see the left bronchus, which is longer and continuing longer distance before the first branch comes off. But sometimes the two bronchi look absolutely symmetrical, and that's what you see in the bottom two X-ray. You can see, if you look at both the bronchi, right and left bronchus looks absolutely symmetrical, and therefore it indicates a situs ambiguous. After determining the situs, you have to go and report what is called the contour of the heart, configuration of the heart. Now, there's a lot of confusion about configuration, contour, and also what it means. Now, configuration is used just to describe the appearance of the heart in the posterior X-ray. We have two types of configuration we generally describe. In one, the apex of the heart dips downwards and outwards, and therefore the apex of the heart buries itself in the diaphragm. Therefore, the long axis of the heart displays downwards into the diaphragm. Okay, this is called a left ventricular configuration. On the other hand, in some hearts, we find that the heart is more horizontally displayed, and the apex is somewhat lifted up from the diaphragm. This apex is lifted up, this apex is dipping into the diaphragm. Now you see, because of the lifting of the apex, this angle is very acute, whereas this angle, because the apex is going down below, is an obtuse angle. Oh, sorry, one moment. This angle, the right one on the left upper one shows the right ventricular configuration. Apex lifted up from the diaphragm with an acute angle at the diaphragm. The right upper one shows the apex dipping into the diaphragm, and therefore there is an obtuse angle from the diaphragm to the outline of the heart. Now, generally, LV configuration goes with left ventricular enlargement. Now, this is not absolute. LV configuration does not 100% mean left ventricular hypertrophy. I will tell you why later. But LV configuration indicates possible left ventricular enlargement. Similarly, RV configuration indicates possible right ventricular hypertrophy. You do not 100% diagnose hypertrophy or enlargement based on just the configuration alone. Okay, but generally upturned apex indicates high likelihood of right ventricular enlargement. A downturned apex indicates a high probability of left ventricular enlargement. Occasionally you see a combination. You see this apex is also pointing downward, but it's also lifted up from the apex. A combination of down and out as well as lifted up from the apex, and therefore it's quite difficult to describe this as an upturned apex or a downturned apex. Probably you can opt for whichever looks dominant, and it may indicate biventricular enlargement, but that you cannot be 100% certain. Pure left ventricular enlargement may also produce that judgment. The configuration just gives you a clue to possible ventricular enlargement. Okay. Now there are more definite clues to ventricular enlargement that we will discuss in the next few slides. Now we have to know what forms the cardiac border. Now I have labeled these X-rays. There are three X-rays: one on top, one on the bottom left, and one on the bottom right. Bottom left and bottom right are more or less similar. Look at the first the top X-ray. Now when you start from the right cardiac border, the uppermost structure on the right side is a vertical line which is due to the superior vena cava. It's already labeled there in blues. Can you see that? Okay. So as you come down from the superior vena cava, there is a small angle, and then the right atrium starts. Right atrium forms a convex bulge from to the right side of the sternum. Okay. Now, sometime between the SVC and the right atrium, you may see a small bulge which is formed by the ascending aorta. Most of the time, aorta lies within the cardiac stellate, and therefore you will not see the ascending aorta form the cardiac border in any view. Now, on the left side, starting from above, first of all, you see the aortic clavicle, of course. Below the clavicle, you see the aortic knuckle. Aortic knuckle really represents the top of the aortic, descending thoracic aorta. And then you see a small bulge, which is the main pulmonary artery. And then you see a depression, which is the angle between the main pulmonary artery and the ventricular mass, which can get filled up when the left atrium gets enlarged. And then you come to the left ventricular, ventricular mass, where the left cardiac border is predominantly formed by the left ventricle. Now, although I say the left ventricle forms the left cardiac border, if you look at the bottom picture now, the left ventricle is shown in red dotted line. The one picture on the left side. That red dotted line shows the left ventricle. So most of the left ventricle is actually lying behind the right ventricle and does not appear at the border. Very little of the left ventricle actually appears on the border. Similarly, the right ventricle. Right ventricle is indicated in blue, the triangular structure outlined in blue. The whole right ventricle lies within the cardiac cylinder. Therefore, neither right ventricle nor left ventricle appears to a great degree on the cardiac border. Therefore, the cardiac border is not a good clue to tell you about ventricular enlargement. On the other hand, right atrium forms the right cardiac border. Therefore, right atrial enlargement can be judged from the plain X-ray post-anterior view. And also left atrium in the normal chest X-ray is not visible because it lies within the cylinder. But that egg-shaped shadow in red marked as the LA. Okay, when the left atrium enlarges, it appears on the left cardiac border where the letters LAA are written. Left atrial appendage is written. It also appears on the right cardiac border because it's very close to the border. And therefore atria are easily diagnosed in the posterior chest X-ray. Ventricles do not clearly appear in the frontal X-rays. Therefore, you often should do additional views. Unfortunately, these days we don't do additional views in chest X-ray because everybody wants to jump into echoes. But if you are in a place where echo is not readily available, you want to save some money for the patient or something like that, you always do a lateral chest X-ray. You do a lateral chest X-ray, and you can do this in any place, say even in primary health center. When you do a lateral chest X-ray, you draw a line from the anterior border of the trachea. You see the dotted line in the chest X-ray? Draw a line from the anterior border of the chest X-ray and continue it straight to join the spine. So it forms an oblique line. You see that the entire cardiac mass is in front of this line. No part of the heart comes behind this line. That means the left ventricle and the left atrium, because left ventricle and left atrium are the posterior most structures in the heart. Therefore, left atrium and left ventricle are not enlarged. Now, look at the front of the heart, which is that is just behind the sternum. You see, between the heart and the sternum, you see a clear black area. That means there is a retrosternal space between the heart and the sternum. That means the retrosternal space is empty, filled up with fat. Now, when the right ventricle enlarges, this space gets obliterated. So, a lateral view is the best way of determining whether right ventricle is hypertrophied or whether the left atrium is hypertrophied or whether the left ventricle is hypertrophied. I'll show you how. Now, if you look carefully, there are two X-rays here. Now, the bottom X-ray, one X-ray at the lower level, can you see, draw a vertical line from the anterior border of the trachea, very well seen because PTR is more than 65% in this chest X-ray, and the apex is dipping down and out into the diaphragm. It gives you a clue that the left ventricle must be enlarged. This is a clear clue to left ventricular enlargement. But you have to confirm it by a lateral chest X-ray. If you see the lateral chest X-ray and draw a line from the anterior border of the trachea, now this you must be able to clear. I mean, if not clear, tell me on the chat box. Where trachea is there, and if you draw a vertical line from the trachea downward, the lower part of the cardiac fillet, much behind the trachea, overlapping the spine. Therefore, the left ventricle is clearly enlarged. Now, if you find this sign, you don't need any ECG or echo to confirm left ventricular enlargement. Okay? So that's left ventricular enlargement. Right ventricular enlargement, I already explained to you. Right ventricular enlargement is not diagnosed on frontal chest X-ray. Please, the examiner will always ask you, is the right ventricle enlarged? And invariably, students will say yes or no or maybe whatever it is. Your answer should be right ventricle does not appear in the border in a frontal chest X-ray. A frontal means the anteroposterior, posterior both. And okay, for a lateral, for a right ventricular enlargement, you need a lateral X-ray to look at the retrosternal space. On my right is a normal retrosternal space which is black, and therefore right ventricle is not enlarged. And on my left is a patient who has right ventricular enlargement, and therefore the retrosternal space is obliterated. This is another example of right ventricular enlargement, obliteration of the retrosternal space. Right, now we come to vasculature. Now this is an example of normal vasculature. Now, what is normal vasculature? Something which is, you have to look at this and make up your mind. But it also depends on the clinical background of the patient. You know, if the patient is cyanotic or not cyanotic, is having signs of a shunt or not. Therefore, mild plethora, you have to, you want the clinical signs become very, very important. But this is a normal example. For example, the main pulmonary artery is not too big. The hilar artery is not too big. You see arteries in the medial 1/3 of the lung. You see a few arteries in the middle third of the lung. No arteries in the peripheral 1/3 of the lung. The branches are tapering from the hilum towards the middle 1/3, and that's it. So that's the normal chest X-ray. On the other hand, the pulmonary arterial marking can be increased. Whenever they are increased, that means the pulmonary artery gets dilated. So let's talk of the main pulmonary artery first. Main pulmonary artery normally is just straight, or it forms a gentle bulge or a straight line, and therefore it's separated from a tangential line from the aorta to the ventricular outline. You draw a line. This distance is probably less than 15 millimeters in an adult patient. This is considered normal. Slight bulge is considered normal. Sorry. Okay. When the main pulmonary artery starts bulging more than 15 millimeters from the cardiac cylinder, or it goes beyond the tangential line from aorta to